You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Good morning and welcome to Health Matters with the Medicine Center Pharmacy. I'm your pharmacist, Paul White. We're very glad to join us. Before we begin, I'd like to thank our sponsors, Aultman Health System, Studio Arts and Glass, and January Appraisals and Liquidations. Today, Nancy and I are broadcasting from our administrative offices. And Nancy has a lot of questions for me today. Go for it.
Indeed, I do. So your healthcare is a partnership between you and your healthcare professionals. As your partner in good health, we want to help you take responsibility for your healthcare, and that includes knowing and understanding your medications and therapies, and to help you raise questions and concerns with your physicians and your pharmacists. As your pharmacy team, we are your most accessible healthcare professionals, and we're here to talk to you all day, every day. Right now, it's that time of the year when everyone is reminding you to get your annual flu shot. Paul, can you talk about when you can get your flu shot and if listeners can expect any side effects or downtime after their flu shot?
I do believe we have some vaccine already. Is that correct?
That is correct.
And we will be getting a lot more. The anticipation for this fall season is that the flu will be around, and that we sense and feel that more and more people are going to be getting flu shots this year. Of course, in an effort to, because of all the activity with corona and people sick with that and da-da-da. So side effects might be just a slight fever with the flu vaccine and a little itchy arm or pokey where we stick the needle in your arm, okay? So we can't make it painless, but it's pretty painful, okay? And and not a lot of aggravation, okay? If it keeps you from getting the flu, hooray, okay?
You recommend Tylenol after you get your flu shot to alleviate any of those symptoms,
But
Paul?
it would be fine, yeah. And that probably is the best product to use, the Tylenol. Acetaminophen, which is the generic name, so...
Paul, I don't know if our listeners are aware, but 70% of Americans got their COVID vaccine at a pharmacy.
I know.
So we're anticipating that because of that awareness that folks can get vaccines at the pharmacy, that there might be increased demand this year. And we hope to see each of you at our pharmacies to get a flu shot. Paul, can you get a flu shot and an ammonia vaccine at the same time?
I do believe you can. Okay. Right now, our pharmacies have many, many different vaccinations available. And call the pharmacy, check to see if you need anything in particular, or even ask the pharmacist what the pharmacist suggests. That if you haven't had certain vaccines, maybe they will suggest that you might consider getting them with us. So anyway, we do have a guest this morning also, and he has, I think, on the air. Are you sure? Are you on the air, Doctor?
I can hear everybody if everyone can hear me.
Okay, super.
Oh, that's awesome.
Super. Now, I want to make sure I pronounce your last name right. Is it Ko?
No.
Not good, huh?
Not good. Not even close. I'm sorry.
Okay.
It's Knox. Dr.
Knoch. Knoch.
Yeah.
N-O-X. Okay,
Yeah,
good.
yeah.
Okay, Knoch.
Not spelled anything like it, though. I can tell you that much.
Okay. All right. We're chatting with Dr. Matthew Knox, Medical Director of Aultman Pulmonary Rehabilitation. Good morning, Dr. Knox, and welcome to the show.
Good morning. Thank you for having me.
And my son, Brad, is taking his... the other participant normally on this show is taking his son back to college this morning. So Nancy Warmby, president of our company, Medicine Center Pharmacies, is subbing for Brad. So here we go. You are on, Nancy.
Okay, so for patients diagnosed with chronic lung conditions, attending a pulmonary rehabilitation program can be a lifesaver. It can help them manage their symptoms, reduce hospitalizations, and most importantly, improve their quality of life. This morning, we will talk to Dr. Knoch and learn more about Aultman's Pulmonary Rehabilitation and the steps taken to improve patients' quality of life. We'd like to remind our listeners that today's program is also available on our podcast, which can be downloaded from the App Store on your mobile phone. Look for Health Matters with the Medicine Center Pharmacy, and you can listen to any of our programs anytime.
So, Dr. Knox, welcome to the show. We're happy to have you today. Please tell our listeners a little bit about yourself and your background.
So I'm a board-certified pulmonary critical care physician here at Aultman Hospital. We have a private practice, Pulmonary Physicians Incorporated. It's myself and 6 other doctors. We have nurse practitioners in our group. We'll get into, I think, a little bit more of that later. I was actually born and raised in Canton and graduated from Plain Local.
Oh, well, no kidding. Glen Oak?
Glen Oak, yeah.
Glen Oak, okay, all right.
And then spent 8 years in Columbus between undergrad and went to the Ohio State University for medical school. And then from there, moved to Cleveland and completed my training in internal medicine and pulmonary critical care fellowship at University Hospital's Case Medical Center.
So do you have a specialty?
So my specific specialty would be pulmonary critical care is what I practice. Within pulmonary, that obviously encompasses a large, facet of diseases, anything from asthma to COPD, emphysema, bronchitis, pulmonary hypertension, pulmonary fibrosis, and most recently, we've seen a lot of COVID in the past several years. The acute management and treatment of COVID, and then the sequela of COVID, and getting patients through that part of their lives, and hopefully better, in the long run.
Jeez. So, how long have you been specializing in this practice?
So I completed all of my training in 2012. So, I guess I came to a realization when I was looking, through the questions for the interview that I've been doing this for 10 years already, and time has flown. So between 10 years of practice and the 6 years of training, it's been a you blink and you're here.
Yeah, you wake up on Monday and it's Friday already. I know how you feel.
Yeah, especially when you do the ICU.
Yep. I can imagine. I can't imagine. So, Okay.
So, Doctor, I know you mentioned that you've been caring for a lot of COVID lately, but what other types of patients do you care for?
So, our practice, we see everything from, as I mentioned, the asthma, COPD, emphysema patients. We see patients with a pulmonary fibrosis. I don't do sleep medicine myself, but 3 of my partners treat the sleep disorders. They're board certified in sleep medicine. So we manage sleep. Sometimes we get just regular referrals for shortness of breath, and have to work through the diagnosis and try and figure out what is causing that for the patient.
Nursing Part 1. Is the supervising physician for pulmonary rehabilitation at Aultman? Can you tell us about how your services have changed because of the pandemic?
So that's an excellent question. If you think about pulmonary rehab, we're taking some of the sickest patients within pulmonary and putting them in a supervised exercise program. So we had to think about how, when patients were gathering, how to keep those patients safe during the pandemic. And, we started off with social distancing. We limited class size. Obviously, masking was very important. But we came up with a unique tool, which was actually a virtual pulmonary rehab. And we used a lot of that through COVID, to be able to have an outreach for our patients and work with them but yet not have, 10, 15, 20 patients in a room together, particularly before we had access to the vaccine. So it did change, how we delivered that level of care to patients. And, now that we're kind of getting back to hopefully closer to normal, we have, a lot of, I think Ashley, who works with us, said we've never been busier with the pulmonary rehab program, which is a good thing.
So what is long haul or COVID, and how prevalent are you seeing that to be?
So long haul, that it's a kind of a vague set of symptoms, and we see patients who, the largest complaint is typically shortness of breath, decreased exercise capacity, but, we can have patients complain of difficulty sleeping, insomnia. We'll see patients that have cognitive impairment, so they just have a difficult time with tasks that they were normally able to execute well before having a diagnosis of COVID. And some patients describe this as, losing the ability to multitask, whereas prior to COVID, they could do 5 or 6 things at once. Now it, takes a lot of concentration to, focus on the things that they need to do. And then, years later, some patients can have, still difficulty with smelling or even tasting impairment. And depression can go along with this as well. So it's a myriad of symptoms, and each patient doesn't need to have all of them. It could be some or the other. But most patients, I think, with long-haul COVID, the bothersome aspect of that is the shortness of breath, because that's what tends to limit them the most in terms of, getting back to normal range of activity that they were used to prior to contracting COVID.
Have you, the medical community, has it figured out why some people get certain issues? Like, now when I had it, I had 2 days of being really tired and nothing else. I didn't, my taster was okay, and the rest of that stuff. But so many people had all kinds of different stuff, as you just mentioned. Why is that?
So this is what I think is somewhat fascinating about this virus, right? It affects everybody differently. And, we know it's the same strain because, as quickly as it spread, particularly in the beginning, people in the same household would have the virus at the same time. And I always found it interesting how one member of the household could have little to no symptoms or perhaps minimal symptoms, and somebody else could have severe disease to the point where, they required oxygen therapy or needed admitted to the hospital or progressed to respiratory failure requiring intubation. So what baffles, I think, the medical community about this virus is how it affects people differently. And, we know that there's a spectrum of asymptomatic COVID, so people who don't even have symptoms but test positive, to severe disease, which in many cases, can be life-threatening or terminal. And so it's a fascinating disease, an unfortunate disease, but I think I've learned a lot about it over the past several years.
Do you feel there's a correlation between...
Pardon me, Nancy. Okay. It is time for our first break, and you're listening to Health Matters with the Medicine Center Pharmacy.
You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
This morning we're speaking with Dr. Matthew Knochs about pulmonary issues, I guess. Is it correct, doctor? Okay.
Yeah.
All right. So anyway, Welcome back to Health Matters with the Medicine Center Pharmacy. Did you know we offer free prescription delivery? Call your Medicine Center Pharmacy to learn about our prescription delivery program. Go ahead, Nancy.
So, Doctor, I was wondering if you noticed any correlation at all between symptoms and how sick a patient can be as to whether or not they get the long haul COVID.
So, to answer your question, Nancy, I think there is correlation. So, what we've seen generally is, those patients who are admitted to the hospital and particularly requiring high levels of oxygen and non-invasive support, and those who proceed to need intubation, they certainly have a increased risk of long COVID just because by nature of the disease process, they're recovering. And I don't know that it's unique to COVID. We've seen this with other respiratory diseases, whether it's a severe bacterial pneumonia, patients that are hospitalized and go through multi-system organ failure, as we oftentimes see with our COVID population when they get severely ill. We know those patients take a long, long time to get better. We do have, patients that never required hospitalization that express long-haul symptoms, and we know there's patients that have been incredibly ill that may not experience, very robust long-haul symptoms. So there's, I think, a correlation that tends towards the sicker you are, the more likely you are to have those types of long-haul symptoms. But there's never a set formula that we can use per se.
So we're kind of in the middle of, or the start of hay fever season and allergies and so forth. And we know that it seems like COVID is circulating pretty strongly right now. What recommendations do you have for a patient who is having symptoms as to whether they should test and whether they should be concerned that they might have COVID versus just common allergies?
Yeah, I think with the, COVID, we've, that from what I understand, I've never had it. Okay, I've never tested positive. So I can't speak as experience of this is what it feels like. But, for most patients, they kind of know, I guess, that they have it, and it feels different than their normal allergies in terms of, maybe they have more chills, more aches. The fatigue seems to be an overwhelming symptom. And then you get into the cough and the fever and all those other symptoms as well. So I guess at this point, it would I would say it's up to discretion. If you feel that you are at increased risk for COVID or getting ready to travel or be close to family, or particularly those who might be vulnerable, getting checked would be important if you're exhibiting symptoms. But like any respiratory symptom, all these are masked kind of, it blends together in time. And what we're seeing with COVID, and hopefully what continues to be the trend, is we're seeing, I think, less of the severe disease that we saw particularly in the beginning. And, that may be a combination of prior infection, the vaccine, and building, immunity through the community. So, and weakening of the virus as well. So we'll have to see, what this season looks like as, flu season ramps up, and are we going to see surge in COVID? We'll probably see increase in numbers, but hopefully not to levels that we saw in the beginning or middle of the pandemic.
Mm-hmm.
With the way our patient base in our drugstores is, they tend to share a lot of information about, I'm better now, but I can't taste anything. It's been 2 months, or my fever is still up and down every day, a degree or a half a degree or something like that. About everybody in the world now has one of those forehead thermometers. So you get up every morning and you check you check your temperature, and for the first time in my life, I've checked my temperature about every day, because it's right there on the kitchen counter, so you press the button, and it's interesting that I'm not ill at all. It's interesting though that how sometimes your mornings your temperature is a half a degree higher or tenth higher or whatever, and I thought that, what's this about anyway? Is that the normal thing with everybody when they're not sick?
Yeah, so, physiologically, we're variable organisms, right? There's nothing about our bodies that's in a constant state. Our heart rate goes up, our blood pressure changes throughout the day with activity, our respiratory rate changes depending on what we're doing. So, temperature can go up and down as a result of, I think normal physiology. We tend to define fever in the medical community as temperature greater than 100.4. So patients will come and say, well, I have a fever, I'm 99.1,
Okay.
Well, technically it's not, but, the medical definition of fever. But, I think if probably what COVID has done, as you mentioned, is, it's increased testing. So now we're noticing these trends. Whereas, prior to COVID, we only checked the temperature most likely when we didn't feel well, but it wasn't an everyday phenomenon. So I think that's just the nature of doing that every day and the variability of being a human organism.
So is this taste thing, is it related to maybe some other disease or some other sickness that they have? Because it's not a lot of people that are telling me this, that they can't get their taste back. Yeah.
It's the strange thing with COVID is that taste and smell, right?
Yeah.
And that involves your cranial nerves. And if you think about the brain fog and some of these other things, including the depression and the fatigue, this, seems like it gets into the neurological system somehow, and causes those types of ailments for patients. But then, we don't know how quickly they are going to recover from that either. And I've had a couple patients actually come in this week and say, it's been a year and I'm still not, I have maybe half of my taste back and still can't smell and things don't, taste or smell the way they used to, even though I can. So it's quite interesting, I would say.
Did you encounter any visual issues with some of the patients with corona?
I don't. Not a large number, I would say, no.
Or hearing?
Again, not a large number.
So it's just a taste, huh? I just think that's really strange.
Yeah. And it's funny how the patients describe it. Actually, one of my friends had it, and he said peanut butter was the strangest thing to eat because it was just mush and no flavor or taste, but that went away for him in his particular case in time. But others it lingers for much longer.
Peanut butter, huh? I love peanut butter. Oh, what a hoot. Well, I guess it's the bottom of the hour and time for the news, doctor, so we're going to have to take another break here. We'll be back in a few minutes, okay?
Okay.
Thank you.
You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Welcome back to Health Matters with the Medicine Center Pharmacy. I am your host and pharmacist, Paul White. This morning, Nancy are talking with Dr. Matthew Knochs, Medical Director of Aultman Pulmonary Rehabilitation. We have a lot more to cover this morning, so let's get back to the show. Where are we at, Nancy? We're jumping around here.
Yeah, I think it's time to talk about pulmonary rehabilitation. And Dr. Knox, would you like to talk about pulmonary rehab and what it involves?
So our pulmonary rehab program is a medically supervised exercise and, importantly, education program for patients with lung disease. And I think historically, we reserve this for patients who had what we would consider to be chronic lung diseases, many of which were advanced, or at least patients had fairly, were fairly symptomatic from those. So it's a 9-week-long program. It involves 2 sessions per week. And as I mentioned, and importantly, it includes the education on the management of the particular lung disorder. And with that comes the supervised and instructed cardiac rehab component to it, and as well as strength training and stretching. And this is done in a group format. So I think it's beneficial for patients because they're with people that have similar issues as they do. And I think it's a very supporting and welcoming environment for those patients. And the goal of the program is to not only lessen the symptoms of chronic lung disease, or in the case of COVID, perhaps a more acute lung disease, but it's also to help keep the patients healthy, out of the hospital, and most importantly, improve their quality of life and get them back to where they may have been before, or at least a baseline now that they are happy to, be able to participate in terms of taking care of themselves.
How can pulmonary rehabilitation help a post-COVID patient?
So this is, pretty interesting because we found this out right through COVID. And it's nice because now the diagnosis of COVID can get the patient approved for pulmonary rehab. And remember, many of these patients are symptomatic for months and perhaps even longer after having COVID and recovered from COVID. And even those with what we would consider to be mild COVID can still experience prolonged symptoms. So, as part of that rehab program, some of this is knowledge, increasing their knowledge of their disease process, their symptom management, and then improving their physical ability. And we monitor this throughout the duration of the program. And we start with 6-minute walks and determine how far the patient can go, and then compare that to midpoint and end point of the program. We've taken patients who have been on oxygen, sent them to the program. By the time they finish, they've been able to come off of oxygen. It's an amazing process to see patients go through this. And I would say the vast majority of patients that come back to our office, either participating in pulmonary rehab or having finished the program, have noticed a significant benefit to their exercise capacity, functional ability, getting back to taking care of themselves and doing what we call activities of daily living. And I think many of us take it for granted, doing laundry or, carrying the laundry up the steps and bending over to put dishes in the dishwasher. And you have to remember some of these patients are at the point they can't even do that when they start pulmonary rehab. And, getting them back to being able to help care for themselves and maintain their independence. And, it's a big psychological benefit for them as well. In addition to, the healthy effects of exercise and, feeling that kind of exercise high from the release of the cytokines and improving the immune system and all those other, things that we, derive as benefit from exercise.
I've heard from several physicians that when a patient comes in, well, doctor, I have this, and I look on the internet and this is what I want you to do, and this is how I want it to get fixed up, What I'm wondering about is the people, the amount of people that actually are walking around with portable oxygen units. I know you know what I'm talking about, and they have concentrators in their home probably to reload things. Is this common that patients come in and say, I want oxygen, or?
So the way oxygen therapy works with the insurance company is there has to be a need. Okay. So, patients can purchase it outright if they prefer, but in most instances, we have to document that there is evidence of desaturation. So that can come at rest, that can come with activity, or that can come with sleeping. We can do what's called a nocturnal oximetry to see if, patients qualify for oxygen in that manner. Once a patient is qualified for oxygen and approved and started on oxygen therapy, then it becomes an issue of what device to get them. The big tanks that they roll around, for many people, that's cumbersome. They're heavy, bulky. They, really limits their ability to go and do some of the things that they would like, because those tanks in time are going to run out. We have smaller, what are called oxygen conserving devices, and then there's the smaller concentrators that actually make oxygen. But we're sometimes limited with those based off of how much oxygen a patient is requiring and whether or not they need it continuously versus on pulse mode. So all of that we tend to figure out, when the patient's evaluated in our office, and then working with what's called a durable medical equipment company, or a DME. And then we can get a patient set up with whatever needs work best for them. And, the ultimate goal is to hopefully improve their functional ability and get them moving and keep them moving.
We have a few rental properties, and one of the people who unfortunately passed away, but that person had a concentrator and a portable unit and was still smoking.
Yeah,
and smoking in the room with the oxygen in it. And I'm thinking, how many people come to you like this? And what do you do to, everybody who works for me, or everybody who I know who comes in the store and is a smoker, I suggest a non-smoking, product. I said, I'll give you a starter dose, to start on the patches or the chewable stuff or whatever. Oh, well, I've already tried that. It doesn't work. It's just, how do you treat these patients?
So smoking is very, very difficult. And if you think about, we tend to see an older population as pulmonary doctors. Asthma might be our younger population, but for those patients who have COPD, emphysema, pulmonary fibrosis, pulmonary hypertension, that's generally an older population of adults. And often the task that we're faced with, and I'm sure the primary care physicians struggle with, and pharmacy and everybody along the way, is, how to get somebody who's been smoking for 30, 40, 50 years to quit when it's become not only a habit, but an addiction as well. Yeah. So for many of them, it's, every day, get up, light a cigarette, have a cup of coffee, get in a car. There's a habit or routine associated with that. And when I'm talking to my patients, first it's non-judgmental. Okay. So I don't say, well, you're seeing a lung doctor, you're smoking, you're a horrible person. That's not what it is. It's how can we help you to quit and figure out a way, to break a 40, 50-year habit. And I always say to my patients, at least, before we start talking about quitting, you have to be ready to quit. And then we can help you. And, that involves, just saying, I'm ready, I know I need to, and I'll do whatever it takes, and I'm willing to accept the help. And then we can talk about the patches and the gums and the different medications available and all the other ways to get people to hopefully quit. But the one thing I can tell you is, for a lot of people that fail quitting, the first question I asked was, well, the 3 times you've tried prior to this, were you ready? And most of the time the answer is no. Mm-hmm. And they say, no, I wasn't ready to quit. And so, I try to counsel people and say, let's think of a way, when you're ready, you come to me and then we can help with that. Because, pushing patches and pills and gums and lozenges and all the other things, I think people are getting acupuncture and laser therapy, and there's a lot of different things that. It's like how
and hypnotize and do the whole deal.
Hypnotize, people will find a way to get them to quit, and I've got success stories from all, every single one of those modalities. I think it starts up here with the patient saying, okay, I know I need to do this for my health, and I know I need help. Can you help? And then those patients tend to be much more successful in their endeavors to quit.
Interesting. It's just amazing to me that people do still smoke. I just can't. When I talk to these people, I just can't understand why they still smoke. But anyway, I guess we have to take another break. After our final break is here, you're listening to Health Matters with the Medicine Center Pharmacy.
You're listening to News Talk 1480 WHBC and Health Matters with the Medicine Center Pharmacy. Now, here's your host, Paul White.
Welcome back this morning. We were talking with Dr. Matthew Knox, Medical Director of Aultman Pulmonary Rehabilitation. So
Dr. Knox, I can see the pride that you have in your program, and it must be incredibly rewarding to see patients succeed and improve in their quality of life through your program. Can you tell our listeners where pulmonary rehab is offered?
I want to start off by saying, as a follow-up to that, I want to thank our staff at the Pulmonary Rehab program, Ashley and Sarah and Kelly and all the people that work with us through that program. They're the ones that are responsible for the day-to-day interactions with these patients. So a big thank you to them. I couldn't do this without them. I look at myself, I'm just a medical director, but they're the ones that are on the ground with these patients and working with them. And so I thank my staff, and they're amazing people. To answer the question, we do have a pulmonary rehab program here at the main hospital, Aultman. We also have a program at Alliance, and I believe we're going to be, if not already starting, pretty soon getting Aultman Orville up and running as well. And, we want to make sure we have access for patients, and we understand many patients come from farther east or farther west, and, getting into Aultman is a little bit of a challenge. So we're trying to expand and reach out further in the community to hopefully get some more people involved that need this service. So that's kind of, how the locations in a nutshell.
Who qualifies to participate in the program?
So the traditional model was those with the chronic lung diseases, COPD, emphysema, interstitial lung disease, pulmonary hypertension, chronic bronchitis. So the things that, people have been diagnosed with, say, for years, okay? Since COVID, we've expanded, the insurers have expanded coverage to include post-COVID pulmonary rehab. So those patients that continue to have ongoing or lingering symptoms for at least 4 weeks beyond their diagnosis can also qualify to be enrolled in pulmonary rehab. And I highly recommend that, particularly for our patients who are symptomatic and limited, to get into the pulmonary rehab. The staff there is amazing. They're going to do a great job in terms of getting those patients, hopefully back to their baseline. And if you think about chronic disease, that's usually something that happens over time. And the day-to-day decline isn't as prevalent or as noticeable maybe as the 6-month decline or the 1 year or the 2-year decline. So what we'd like to see is those patients getting back to where they were maybe 6 months or a year ago, those with a chronic disease, and hopefully with the post-COVID population, getting them back to where they were prior to developing COVID.
If a patient thinks that they want to participate in your program, what should they do, and how can they reach you?
So there's typically 2 ways, either a referral from their primary care physician, that would work, or if they're seen by us or followed in our practice, we can also make that referral. And also, if they're in the hospital, there could be a referral from the hospital to attend pulmonary rehab. But typically, it's most likely done on an outpatient basis. So it would be some outpatient physician, the primary care, or their pulmonary specialist making the referral.
Can I interject something here? There's a lot of talk all of a sudden in the news about a fourth vaccine coming out, COVID. I don't know where health care sits on this issue. Had 3 shots myself, along the way here, and still got it, I guess lightly, not with a taste and all that other kind of stuff that went away for other people. What's the thinking here?
So, this is likely to become and hopefully get to a point where it's more of a seasonal infection, and as it goes away from the pandemic phase. What we worry about with COVID is those dangerous strains where they become more serious. And if the virus itself is weakening and it's becoming, something that we can fight off with our own immune system with a combination of the antibodies we've received from vaccine or prior infection, then hopefully we get to a point where, maybe we don't need to, keep getting boosted. The fourth vaccine, basically we're waiting on guidance on that in terms of, when to get it and who to get it and when. So, we'll wait and see what that shows.
I believe that Pfizer's trying to get that approved by the FDA here, like right now or something like that. So I can't even imagine getting in that fourth shot,
Yeah, and as we move indoors, for the winter.
Sure.
Again, that's when we may start to see some spikes in cases, and and as long as we don't get to the point where we don't have ICU beds and ventilators and things like that. I mean, if we can never be there again, I think we would all be happy.
I'm kind of hearing too that the healthcare is thinking that this is going to be a really rough flu season. Is that out there?
There's hints of that, yeah, and that's why it's important to get the flu vaccine as well in terms of protecting yourself and others. I never really understood the flu vaccine, I guess, when I was younger, and until you realize you can give it to grandma, you can give it to grandpa, and being a younger individual, maybe you don't have severe disease from it, but those who have immune compromise or of advanced age, they can get really sick from those, types of viruses.
Flu shot and COVID shot same time?
Probably not the same day.
Okay.
I know I get my flu shot every year through the hospital, and and then get COVID boosters whenever they're available. But so yeah, the part of the problem is which one do you react to, and a lot of people say, well, I'm allergic to both now because I had a reaction. So I would say get one, and then make sure you're doing well, and get the next one, when down the road in a couple of days or a week or two.
Interesting. Okay, Nate, sorry.
That's all right. Dr. Knox, would you like to share your contact information with our listeners?
So I'm sure our practice is called Pulmonary Physicians. It's here in Canton, Ohio. We're at 2600 West Tusk, Suite 100. Our phone number, do you need to add? I don't know how much information you need from me.
I think it's up to you, what you would like to share.
We can be reached at 452-8844. But, the best way to get in to be seen, although we do see self-referrals, most of the time it's go to your primary care physician, and that way all your records can be sent over. We can have access to the medications that you're on, any prior testing that you've had, and any imaging or any other work that's been done. That way, when you're seen in the office, we can have a more complete plan that we can devise at that visit. So that's our information.
I'd like to offer our thanks to you and your team for staying active during the pandemic, but for everything that you're doing on behalf of our community, because your pride is evident in the program that you're offering. And it's just really nice to see that. We appreciate everything. Do you have a final thought or a final important piece of information that you really hope is our listeners' takeaway today?
Well, I would say, this isn't just about, doctors and specifically pulmonary doctors. There's no way we can do what we do without the support of our staff and support of community and every member along the way. So we're, I think, eternally grateful to everybody that helps